Good morning, everyone. Welcome to Cardiac Sciences Grand Rounds for the 27th of January, 2026. Today we have a prodigal son returning, I guess. Dr. Parekh did his training in core cardiology here. Since leaving us, he's gone out to Ontario in Ottawa, where he's doing advanced multimodality imaging. He's spent a year at the Ottawa Heart Institute doing echocardiography with something of a focus on structural heart, I believe. And this year he's moved on to do training in nuclear cardiology and cardiac CT. So today he returns to us. He's looking at Calgary as a potential place to return for his career. We certainly welcome him if he decides to go that way. But today he's going to talk to us about advanced cardiac imaging, seeing function, not just form, a new era in cardiac imaging. Welcome, Dwip. Look forward to your talk.
And good morning, everybody. Lots of familiar faces, mentors, colleagues, friends in the crowd. So great to be back, and thank you for the invitation to the division. Much appreciated. Let's see. Start out. Like to take this opportunity to say that we are on the traditional lands of the Métis people here on Treaty 7, which is very important. Being from the prairies and the mountains, we have to definitely acknowledge of this fact, especially when there's about 30% of people thinking that they can become their own country. Well, we can't. I don't think we can. But yes, I have no financial disclosures, no industry collaborations, and I am a member at large on the CNCT. Other than that, I have no other disclosures. So, I hear that we're getting a new CT scanner here at the Foothills, and there's a PET program also in the work. So I want to take us through some cases today, with a case with echo, maybe a couple cases with PET and a CT. And really, I want to highlight the importance of functionality. So hemodynamic functionality with echo, and then addition of certain flow quantifications on top of relative perfusion that we get with MPIs. And then lastly, some cool characterizations for heart muscle we can do with CT, with a few examples of what FFR on CT can do. So adding a bit more of function on top of the traditional bread and butter anatomy and perfusion that we get with our multimodal cardiac imaging. So we can start off with our case here, an echo case where and all of these cases I've been either directly or indirectly involved with in the last 1 month. So, these are real life cases. This 56-year-old gentleman presented with chest pain. ECG and echo were done. They showed a thickened LV. He went through an exercise stress test where he showed anterior elevations in his anterior precordial leads. Rightly so, underwent a left heart cath, and his coronaries are pretty clear. He underwent a CMR because a diagnosis of perhaps HCM was invoked. And it was indeed consistent with hypertrophic cardiomyopathy with septal dimensions at around 2 centimeters. No high-risk features. LGE burden was on the mild side, and he had some medication changes because he couldn't tolerate his beta blockers. He was then seen in the HCM clinic at the Heart Institute, continued to have symptoms. He ran about 7 kilometers, 3 to 4 times a week, but couldn't do that anymore. He couldn't even go up his stairs. So there was something wrong there, and that's when we decided to do a stress echo because, well, the MRI didn't show anything. The cath pullback was negative, and we couldn't figure out why this guy was symptomatic because his coronaries were pretty clear, and there's some remaining questions there. So he underwent a bike stress echo, and as you can see here, this is his echo images that we acquired on the initial stress echo. The technologist/sonographer did try their best to grab some gradients to see if there's any LVOT obstruction, but we cannot be sure if that's what's happening. Is that an MR signal? Maybe there is a flash of MR happening where we can't see the left atrium, and we're catching that, so unsure. And on that stress, the initial stress echo, these gradients were recorded and reported, but very with clinical equipoise. And the statement was this could very well just be MR. And, you know, as we see here in recovery in Valsalva, the contour of the gradient is not very classical or in keeping with an LVOT or a mid-cavitary gradient. And the tracings were made quite into what we call the shaggy or the beard part of the gradient, where we don't tend to go usually. So, you know, he continued to have good and bad days. He's now down to smaller meal sizes now because he was feeling worse after eating big meals. In clinic, he had a harsh LVOT murmur when the clinician examined him on after some squatting tests. So this patient was presenting typically of a dynamic LVOT obstruction. So the decision was made to book the patient for a very special stress echo with the cardiologist in the room, both the cardiologist from the HCM clinic and the sonographer. And he was instructed to take a large meal of like fries, burgers, greasy food an hour before his exercise stress echo. So at that point, this was his baseline. So this is his baseline squatting stress echo. You can see there is at least some mild leaflet tip SAM happening here, so systolic anterior motion. And what this means is even if you can't see the LVOT, you know, aliasing or flow acceleration, by definition, when you have SAM happening in these patients, there is an obstructive physiology happening. But we do see here that there is some flow acceleration happening. You know, so we record the baseline images, and lo and behold, the patient was asked to squat 10 times. And as soon as he came up after the 10th time, he was put on his lateral left decubitus, and the cardiologist and the sonographer both got pictures as soon as they could. And here you can see that SAM again, that leaflet tip and the points where the leaflets coapt with each other is actually being pushed into the LVOT. This is not a perfect 5-chamber view, so here you can see that there's at least moderate SAM by echocardiographic definition, so you know, almost reaching 1/3 to half of systole. So we were able to capture that, so at least there was some structural evidence that there is dynamic LVOT obstruction. And then we put on the gradients. And if you look at the contouring of this gradient, it's very much like that dagger shape or that, you know, knife shape we say. You know, there is an acceleration, a slowdown, and a peak towards the end of the gradient. And we were able to get 90 millimeters of mercury at the peak of it while the patient had all of these things done to him. So highlighting why this case was important, well, so this qualifies the patient for mavacamten therapy, at least in Ontario. You know, if you cannot record a gradient that's pathologic of 50 or more, patients really can't go on mavacamten unless otherwise they want to pay for it out of pocket, and it's an expensive therapy. You know, the function of stress echo here is so important because diseases, especially with the heart, are dynamic diseases. They don't happen at rest. A lot of diseases don't happen at rest. So this is why I wanted to highlight this case. The gradient here was not recognized on rest echo or on the stress echo with the bike with left heart cath on pullback or on cardiac MR, which, you know, usually is our gold standard for tissue characterization for cardiomyopathies and scar burden, etc. So 6 months later, the patient is feeling great. He's back to 9 out of 10, 10 out of 10 functionality. He's running, he's doing well, and he's continued on with his diltiazem and his mavacamten. So why stress echo? Well, we know from the recent JACC HCM, you know, paper that's been reviewed by them that almost 52% of patients increase their gradient with exercise as compared to rest and provocation. So that's 1 out of 2 patients that you will unmask a gradient in if you get them to exercise. And about 40% of those 50% of patients had substantially increased their gradients over 50 millimeters of mercury, which is our cutoff for you know, getting your mavacamten. Here, this shows that patients who undergo exercise, both at the lower gradients and higher gradients with exercise, will statistically significant, and it's a statistically significant finding, will show a much higher gradient. So much so that, you know, you get around gradients that are 25 millimeters higher in the lower end, the 30 to 49. And when the patient already has an LVOT gradient over 50, you can get gradients up to 100 millimeters of mercury, just like we saw in our patients. There was a case documented that a patient went up to 130, 140 millimeters of mercury, and became symptomatic. So, and this 2017 study showed that amyl nitrate and exercise were quite important. Traditionally, we don't use IV amyl nitrate. It causes a lot of symptomatology, low blood pressure after the fact of the exam, but goes to show that exercise stress echocardiography is a strong provocateur of LVOT obstruction than Valsalva or rest echo alone, especially in patients that have exertional symptoms. Additionally, we see that if we were able to do peak treadmill echoes, and these are very hard. We don't do this at the Heart Institute because the patient's running on the treadmill. You have to get them right away on their left decubitus and then scan. Or in some centers, there's been some trials and papers that say you can scan the patient upright, but the windows are very hard to get. The lung is in the way. You can't get to the apical 5 chamber. So what I wanted to highlight is within reason, you can do a post bicycle or a post treadmill, and they tend to be the same level of provocation. So that's why we use the bike at the Ottawa Heart Institute, which gives us a lot of success. Why does this matter? Why does this matter? Why does this matter that we're giving these patients these stresses, and we want to find out if they do have resting or provocation gradient? Well, because we know that if the patients do have gradients or have LVOT obstruction that's dynamic or at rest, well, they'll get more symptoms. They tend to get hospitalized more often, and in young people, they're debilitated. They cannot function just like our patient. So that's why it's important for stress echo as an addition on top of echo, which is already a dynamic test to offer these patients. So most patients who are symptomatic and even on mavacamten therapy, beta blocker therapy, get fairly regular stress echoes if their symptoms are not under control and everything else have been ruled out, and we're able to get a fair majority of them to show us their gradients are still elevated. And guidelines do reflect this. Patients who have a change in symptoms, well, we should re-echo them. Patients who do not have rest gradient or provocation gradient, well, we should be exercising them to get a gradient that's more hemodynamically compatible with their symptoms. So my point being in this case, if symptoms are occurring during exertion, we absolutely have to test for them on exertion. It does change patient management. It changes their morbidity. And there's now some recent data, it's retrospective and observational, that's saying that there might be some mortality benefit from mavacamten, but there's been no prospective randomized trials that have been published thus far that I know of. Case being that many pathologies are dynamic, so we need to test for them. Additionally, with stress echoes under load, you will see in panel F and G here, this is a TEE view. There's a posteriorly directed MR jet in panel F. That means there's SAM happening, but at the same time, there's also an anteriorly directed jet. So that's not normal. That's not pathognomonic for SAM. That means this person has mitral valve disease, which is quite commonly found with hypertrophic cardiomyopathy. So additionally, this tells us that this patient, even though if they're on mavacamten, in the future might need a surgical option to take care of their disease if they continue to have progressive MR at load. So other applications of stress echo that I wanted to highlight that are important with dynamic physiology are quantifying mitral regurgitation. Do patients have mitral regurgitation that gets worse? Pulmonary hypertension reserves, and are the lungs capable of accepting the blood flow coming to them? Diastolic dysfunction. A lot of patients, when they're resting, have normal diastology, and we know the ASE 2025 has simplified our diagnosis of diastolic dysfunction on echo. We only look at 2 things now and are able to diagnose diastology, although the TR velocities have moved up a little bit to make our diagnosis more specific. So this is an area that's not very well experienced with, but that is an option. And additionally, I wanted to point out the last thing that we commonly do to qualify patients with stress echoes is something called a projected aortic valve area. So this is a really important exercise we do because a lot of the times we know that in stress echo, the patient has a failing LV. They don't have that stroke volume reserve that we need to get them to qualify them to say, okay, this is either true AS or pseudo AS. So Dr. Borbosh, who's the director of echo at the Heart Institute, was part of a big study called the TOPAZ study, where they took a look at 90-some patients, I believe, and they evaluated that at resting hemodynamic valve flow rates of 250 milliliters a second, what does the aortic valve look like? And they did a whole study where they calculated the valve compliance. So when you put someone on dobutamine, what's their valve area at 0, 5, 10, 15? You make this graph of valve compliance, and you extrapolate from this graph when their stroke volume will be at 250 mils per second, what their aortic valve area would be. And why this is important is because with all statistical power, this was found to be the biggest variable that correctly classified a pseudo versus a severe aortic valve. So any patients on stress echo that don't actually meet their 1.0 or higher cutoff and have equipoise saying, is this person pseudo or true? We do put them through the TOPAZ algorithm and actually report their projective valve area because of this study. So the takeaway being, when resting echoes are normal, well, physiology will reveal the disease. So if symptoms are occurring at rest, we should also image the patient at rest. Next, when structure and wall motions aren't enough, well, we can then go on to assess perfusion and quantify perfusion. So cardiac PET is the new kid on the block, but is not as new. It's been around for a while. And why PET over SPECT? Well, we know that PET has advantages over SPECT because of many reasons. There are some downsides. The cameras are more expensive. Tracers are typically more expensive, but the tracers are physiologic. So we calculate something called roll-off values. So tracers for SPECT don't tend to go down the arteries and into the myocardial cells as, let's say, efficiently or as physiologic as blood and oxygen do from our blood. But the PET tracers tend to have better relationships. So that's what makes them, one of the things that makes them more sensitive and specific for cardiac perfusion. The radiation doses are reduced because these are higher power tracers, they're higher energy, some of them. So their half-lives are anywhere from 1 minute to 2 hours as opposed to 6 hours for some of the SPECT tracers. And then we can actually quantify the blood flow down the coronary arteries with with PET, pardon me. So what is PET and what is a positron? Just a quick kind of lay of the land. SPECT is single photon emitting technology. So, a single photon from a part of the heart is emitted, it's sensed by the sensor, and then you make the map of the heart. Well, in the radio tracers that we use for PET, when they decay because of their nature and their physics, they let go of something called a positron, which is the complete opposite of an electron. It's like the anti-electron. So it will, and physics always has to balance out, it'll go find a similar energy electron in the atom, and then they both meet up and they destroy each other completely. When this happens, they let go of two light energies, two photons that are detected by detectors. And then these detectors go through immense amount of work that they have been designed to do, like multiplying this signal 1,000-fold for us to be able to see these photons, because a lot of the photons get absorbed by the body. And this is what a PET scanner looks like. And a single detector can detect a single photon and then multiply the signal. In this right here, there's 60,000 detectors, so this is where we get our spatial resolution, and this is adding on to your spatial resolution from all the things we talked about in the past. So when you have these detectors around the human body, and you can imagine the heart sitting there in the center, all of these photons are coming out of the heart everywhere, hitting all these detectors, we're able to build a pretty good model of where the blood is perfusing the heart and where it's not. And the diagnostic accuracy of PET has been time and time again proven. There's higher overall sensitivity for detecting significant coronary disease. And importantly, the specificity is similar, meaning that PET improves detection without increasing false positivity. So PET finds more disease, more true disease than SPECT. And there are technical advantages, spatial resolution, higher signal to noise ratio, lower radiation dose. I want to highlight an interesting case I saw at Christmas. I was on call, I was the only one in the lab. This case came across 84-year-old gentleman, quite aged, significant T-wave inversions noted on his ECG by the GP, has a history of dyslipidemia, and nothing else going on. And the physician had wrote, I'm concerned, can we assess for myocardial ischemia? And the triaging system triaged him to a PET as opposed to a SPECT because we're extrapolating because the ECG was quite abnormal. This is a very abnormal looking ECG. This was his resting PET ECG. And when I looked at this ECG, I thought this patient might have something called apical cardiomyopathy, apical hypertrophic cardiomyopathy. It's very pathognomonic. Lo and behold, we'll find out what ended up happening to him. This is his stress ECG. So there's a component that we also get with PET is what the heart does electrocardiographically. It does become positive, but then I started to wonder, well, does he have epicardial disease or does he have microvascular disease because of the disease process I was wondering about? These were his gated images. So what I want to point out here these are beautiful, okay? This is rubidium. In the vertical long axis, you can see both the papillary muscles. You can see all 17 segments of the heart. You can diagnose hypokinesis, akinesis, dyskinesia on these. You can take a look at the RV size. You can take a look at the LVOT and the membranous septum. You can see the RV contracting in the short axis as well. So from this point of the presentation onwards, I want to just leave with you that the top row is always going to be stress. The bottom row is always going to be rest. So stress and rest. And you can see here, the gentleman at rest had a normal ejection fraction, normal wall motion. But at rest, this apex right here, where is my mouse coming across? Okay. Okay, this apex right here has become akinetic to almost dyskinetic, especially in the apex inferior apical area. So I already have a higher suspicion of looking at the perfusion scan with greater sensitive eyes. And I was always look at the gated images first as to not bias myself on what I'm going to see on the perfusion images. Because if there's wall motion, then you have to be more mindful of not just saying something is an artifact. And this is what we see on his PET perfusion images. You can see on the vertical long axis very clearly that apex goes away. At rest, the apex is present. At stress, the apex is bitten out. So there's disease there. There's a small, you can argue maybe 2-3 segments of the area of the heart that has moderate disease. So there's moderate tracer reduction there. Something important I actually want to highlight here, more than the perfusion defect, is the way the rest images look. The apex of the heart is a very thin area of the heart. It doesn't get a lot of blood flow because there's not a lot of muscle there. With the spatial resolution of the heart, we see that that is the thickest part of the heart here, okay? This is what looks like a crab claw. We call it a crab claw sign, and it's very sensitive and specific for apical hypertrophic cardiomyopathy, and that's what we see. And that's the part of the heart that is diminished in blood flow right here. So that also gave me a clue that this patient likely has apical hypertrophic cardiomyopathy. I was becoming more and more sure. Last thing that PET has to offer is flow quantification. We can actually calculate in milliliters per minute per gram the blood flow going down the coronary arteries of the heart. And here we can see that at rest, his quantification were fairly normal. So the values we go for around, 0.6 to 1.2. And he gets stressed. So this is his stress flows. They augment fairly well, actually. They're in the mid ranges. And then his reserve, that's the number most of us know, that the coronary flow reserve is over 2. So overall, his prognosis, looking at the global picture, is not bad because his coronary flow is able to augment quite nicely with stress. But there's something here that is traditionally spoken of as a high-risk feature on PET. That's something called coronary steal syndrome. So when we do this delta map here, there's blood from the apex of the heart that's likely not flowing the way it should be. So there's a negative physiology happening there. It's being stolen away. Now, I don't think, and a couple people and I discussed, we don't actually think this is what's happening because of cardiomyopathy and the way the artifacts are calculated with the PET machine and the probability of this being a cardiomyopathy and not coronary disease. So this is likely just a reflection of the apex being very hypertrophied and on stress, having a significant amount of microvascular disease. Until we actually get more diagnostic imaging through, either, let's say, a cath or something else we're going to talk about, we won't actually know if it was epicardial disease or not. But this shows you a very good, sensitive and quantified map of the blood flow of the heart. So how does this work? How does the myocardial blood flow work? That's the point on PET I wanted to make, is relative perfusion for PET is great, but we have additional information on top of relative perfusion that we can add onto PET, and that's myocardial blood flow. So what happens is when you inject this radio tracer into a patient's body, the machine acquires very short-term frames as the tracer is going through the different chambers of the heart, as you can see here, RA, RV, then into the LV, through the aorta and into the myocardium. And these models are made with very complicated physics and attenuation correction of the human body, where then we're able to record the activity of the radio tracer in the blood pool, compare it with the myocardium, and come up with values of how blood is flowing down the coronary arteries. And this result allows us to quantitate assessment of the flow reserves and microvascular coronary disease with relative perfusion. And we know, Murthy and all did a pretty large study to show us, that both lower stress blood flow and flow reserves predict higher cardiovascular mortality. So here we see that there's a lot of variability between myocardial blood flow, stress values in different manners of calculation. So you just kind of put a ROI value over the heart, there's some algorithmic analysis, and there's some AI involved, but there's a wide variability of stress quantification. But when we actually take the reserve value, so is the flow able to double? That's what I mean when I say reserve. From breast to stress, can your coronaries accept double the flow? Is there disease or not? And if that flow is doubling, then we can prognosticate the patient. And these guys showed that MFR, or reserves, were not as variable as the quantification of stress blood flow. So that's the value we tend to use. Thus, this is globally accepted now as a cutoff of 2, where myocardial blood flow reserve on PET, if you're over 2, for a person who has no other cardiomyopathies or any other status, is fairly normal. And then we divide their prognostication based on what their reserve values are. So why does this matter? Why does this flow and reserve actually matter? Well, let me show you something before we got there. So we know that the more ischemia you have on PET, the poorer you're going to do. We already know that, and that's been proven in this 7,000 patient study. The higher, here this graph shows you the more ischemic myocardium you have, the poorer you're going to do. We also know that lower tertiles of reserve and stress flow are associated with progressively worse MACE-free survival, demonstrating the incremental value of PET quantification over the semi-qualitative perfusion data we get. So you can see here that The lower the reserve, so red line, the worse you do. This is important because even if you don't have an ischemic myocardium, when your parts of the heart, the segments of the heart, the 17 model, when you have two or less of those that are ischemic, it still pans out. A lower reserve gives you a poorer survival. So now that we know about PET perfusion and these flows, I wanted to highlight a case I came across. Cardiac transplant patients, and how do these values actually help us with the cardiac transplant population? Because we have a lot of these patients come through our scanner, and I wanted to learn a bit more about them. This 35-year-old gentleman was coming through. He had an orthotopic cardiac transplant in 2014, and he was there for his annual PET perfusion for CAV monitoring, so cardiac allograft vasculopathy. That's the disease you get after cardiac transplant, and it's the leading cause of morbidity and mortality in these patients. This was his perfusion. You can tell because of the higher resolution and sensitivities that there's something wrong. And why I say that is because there's chunks of the heart missing in a symmetrical fashion. So that raises a potential question for us. We know that this is very secondary likely to motion of the patient. So with our algorithm, when patients are breathing, patients are moving, we're able to put on special PET algorithms because we have underlying CT data on the patient. And when we put on these motion correction, what we call dual gating, I want you to focus on these two rows here. So the first row is stress, the second row is rest. The chunks in the anterior wall and the inferior wall almost go away other than the base of the heart. That's where his disease is. So this goes to highlight the importance of attenuation and artifact correction with PET we have because we have CT data. So, he does have a little bit of disease that you can see in the base of his heart and kind of a proximal LAD, maybe the diagonal territory, but the rest of his heart looked fairly good. You wouldn't expect anything too abnormal. And he had a diagnosis of CAV prior, where he received a small stent in 2018. So he's a patient that we're monitoring, These images don't look as nice as the ones before. And why that is because the patient moved. They're not as sharp, they're blurry. The edges of the heart and the blood pool, the differentiation is poor, the signal to noise ratio is poor. The patient had moved. And that's what was important for the perfusion, is we can actually correct for that on PET. Importantly, when we did the flow quantification for this patient, what I want you to notice is he was normal at rest. He did not augment his flows. The heart still stayed blue, very similar to what he was at rest. And his flow reserve here is 1.86, which is not where most patients should be, which is not where this patient should be. And we know this from the data that I'm going to share with you. Another thing is his coronary vascular resistance, this gray number, 87.2. So when we manually calculate this, actually, that's incorrect. When we manually calculate this, it's 116. And that's the vascular resistance of the coronary bed. Why this is important in these patients is because we know CAV is also a microvascular disease process. That's where most of allograft vasculopathy starts off and is happening. So why PET in cardiac transplant patients and not SPECT? Well, SPECT requires a regional reduction in comparison to other segments to display abnormalities. It's not as sensitive as PET. CAV or CAV is a diffuse process with multiple segments being underperfused, leading to SPECT underestimating the burden of disease. And with rubidium and O15, we traditionally only use rubidium, we can actually quantify the perfusion. And this big study set out to test the diagnostic performance of PET versus cath, which is currently the gold standard of testing for CAV in transplant patient. The 40 heart transplant patients were selected for the study design, and they underwent rubidium PET and coronary angiography, both with multivessel IVUS, so ultrasound of the coronary vessels, and IFR on cath. What we found was that non-invasive PET flow measures tracks invasive coronary physiology very well in transplant patients. The coefficient was, moderately powerful. One weak to moderate, but the way to analyze this study, as per the authors, was that there is a moderate relationship between invasive CFR and PET-corrected MFR to hemodynamics. This means that PET is reliable for identifying abnormal coronary vasodilator capacity. You know, the reserve. Pardon me. Even though PET measures global myocardial flow, while invasive CFR measures individual vessels. This here shows, again, the agreement. So the corrected flow reserve with CAV variables from the cath. So there is a delineation on cath that we do for very no to minimal disease, which is a CAV variable of 0 to 1. And then 2 to 3 are moderate or severe stenoses or multivessel disease. This shows that corrected reserve on PET agrees with statistical significance with severe disease on cath with blood flow. Now, the panel A here shows that PET is not ideal for matching angiographic grading because angiographically we might miss early disease as well, you know, when it's just starting out. Panel B shows that when angiography does show advanced disease, PET-B reliably detects impaired hyperemic flow with a good area under the curve. Panel C here shows that PET accurately detects diffuse epicardial disease and intimal thickening, the true early hallmark of CAV. And D, panel D, PET reasonably identifies microvascular dysfunction, though invasive, you know, IMR or index of microvascular resistance on cath remains the gold standard still. So what does this all mean? So this means that combined PET assessment provides very high sensitivity for screening and very high specificity for confirming cardiac allograft vasculopathy when you have the combinations of these two functions happening. So still visible? Yeah. Perfect. So the authors concluded that you know, the cutoffs that they proposed were a corrected reserve under 2.9, blood flow of under 2.3, a stress quantification, and cardiac vascular resistant value of over 55 can be used on PET to screen and monitor patients after cardiac transplantation. So interestingly, at the Heart Institute, the patients tend to get PET 1 year and angiograms the next year. And that way we can reduce the amount of physical risks that we're introducing with cardiac angiography to them and still monitor them for CAV on a yearly basis. Dr. Miller was involved in a 2020 study which showed that all 3 PET flow measures detect significant CAV variables reasonably, and no one is clearly better than the others for diagnosing the flow reserve. Pardon me, the flow reserve tends to be slightly higher, but not statistically significant. And correcting for rate pressure products, so that CMFR I was showing, does not really improve accuracy. So panel A here shows the lower the stress blood flow you have, the higher the mortality in these transplant patients. Panel B shows MFR, the vascular reserve, powerfully stratifies mortality risk. And panel C is the corrected MFR, which is very similar to the uncorrected MFR, shows no better prediction than uncorrected. So what does this mean? Quantitative PET predicts survival after transplant. MFR, or reserve, provides strong separation, and preserved MFR identifies a low-risk population. So it's a good screening tool. Severely reduced MFR identifies a very high-risk population. Then we can go on to give them an angiogram and step up their therapies to either better anti-rejection medications or statin, they should already be on, or Repatha or other PCSK9 inhibitors. So in essence, PET-derived reserve is a powerful non-invasive predictor. Can skip through this. And Dr. Miller and cohort did also show that adding perfusion defects and low ejection fraction that we can actually see on PET also markedly improve our risk stratification of these these cardiac transplant patients. The guidelines are a little behind on this. The IS-HLT guidelines from 2023 give PET level class 2A level B evidence. But from my understanding of the transplant world is pragmatically the practice has changed, where in centers where PET is more available, this PET is being more and more used for transplant patients. So what I wanted to show you there is the function of flow quantification on top of PET perfusion and how we can apply it to special populations and not just coronary artery disease. And it does also pan out. So this patient currently, we decided to give him a CT coronary angiogram because there's suspicion for epicardial disease due to, the microvascular reserve being pretty strong, is low, and the pathognomonic disease process having unearthed itself. So he's going to undergo a coronary angiogram, a CT coronary angiogram, pardon me, as opposed to jumping right to a cath lab. Patient panel B here, the transplant patient, has undergone cath, and the cath does show progressive intimal thickening of his LAD. The cath does show that he is having more aggressive CAV. So with PET, we can quantify physiology and pathology. But then where exactly is the disease? If you want to see where the disease is and how prominent it is, you either need to then go for something that takes a look at the anatomy directly. So either coronary angiograms or CT coronary angiograms. Cardiac CT has already been incorporated in many centers in the chest pain care pathway. We know from Scott Hart trials and PROMISE trials in the long analyses of these that they do change management and prognosis of the patients. There's better outcome when there's no plaque burden on the heart with plaque quantification. And it does have a good information we can get from the cath for high-risk plaques that invasive cath might miss, such as low attenuation burden, epicardial fat levels, and microcalcification. But there are limitations of coronary disease as well. There's impossibility, of coronary cath from CT. There's impossibility to assess the functional significance of these coronary stenosis. And there's moderate positive predictive value for detecting inducible ischemia just on your standard coronary CT angiography. And that's where FFR-CT comes in. We can actually do functional flow reserves on CT. Now, it's not widely available in Canada. There's only one center that does it, but this is an option working with industry and the guys who've been the inventor of this. And this technology is out there to risk stratify further your moderate risk patients. So they don't have to undergo invasive cath. And it also gives us, importantly, I want to highlight that it also gives us a differentiation of patients we actually do send to cath, where the patients we're sending actually have true disease, actually have disease that need to be intervened on that will make a difference. And that's where the power of CT-FFR comes in. There are three key principles, and this is a bit technical, so we don't worry about the physics of it. But the way it works is we calculate the total resting coronary flow relative to the ventricular mass, and then some algorithms calculate, what flow at maximal stress or vasodilation would be, and then give us maps. So this is what the algorithm actually does. You get a CT cardiac angiogram, and the AI goes through reconstruction and makes the voxels sharper. You construct a coronary artery tree, and a mesh is generated by the company. Then, depending on how much myocardium is provided by each coronary arteries and its branches, a calculation is made for resting flow resistance. An algorithm is applied to this, simulating adenosine at 140 milligram per kilogram per minute dose, and then computational fluid dynamics is done that takes into account what the human body traditionally does with stress and vasodilation. and you get a map as such. So this gentleman is 52, he was having chest pain, and there was a moderate lesion in his mid-LAD. So you wonder, he's having chest pain, is moderate, can we treat him with medications, or does he need to undergo invasive coronary angiography? Well, these are great cases to be sent to CTFFR, the heart flow company, because this gentleman came back with a value of over 0.8, and he was treated with intense medication, and he continues to do well 8 years later. So, and clinical studies have validated that using an invasive FFR of 0.8 as a reference gold standard is where the cutoff was, and it agrees with cath. And I'll quickly take you through some evidence, some three main studies here. And I want to end with a cool case on myocardial tissue characterization on CT. So Discover Flow showed that there's proof of concept here. This trial did not meet statistical significance because there were limitations, but it does show that the area of under the curve per vessel and per patient of CT-FFR versus invasive coronary angiography is possible. So this laid down the pathway for further trials for us to experiment with, and then was brought on by the de facto trial, which added on to this trial with 17 centers involved. And that also showed that the goal of FFR-CT versus invasive coronary angiography, the observer accuracy was around 73%, which makes for a very accurate, pretty good accurate test. Unfortunately, the primary endpoint was not technically met because there were some limitations with the confidence interval here as well. Then came the next trial with around 254 patients, which then finally showed with statistical significance that the sensitivity and specificity of these trials were sensitivity around 86% and specificity around 79%. And it confirmed that there is a trend. And the accuracy of this trial and the tighter confidence interval were set because of newer technology, newer machines, and better protocol. So patients were getting nitroglycerin more regularly, were getting beta blocked more regularly, and better machine resolution and spatial resolution. So we've now validated that CT-FFR is a good test when compared to invasive coronary FFR, and we can differentiate patients with further downstream ischemia with it. Why does this actually matter? Well, this advanced registry was a registry that took a look at a trend of lower MACE and significantly lower cardiovascular death and MI in patients with a negative FFR. So if you were values of 0.8 were over, then you didn't do so badly. So this has also been confirmed. And importantly, in terms of what happens to patients, we tend to reclassify patients better to medical therapy as opposed to getting them to invasive angiography more. So both the core lab and classification by site were better improved, with patient selection going to PCI were better targeted. We knew where to go, where the ischemic lesions were, and we knew there were less false positives when patients ended up on the angiographic table. So something to highlight is we did not take away the caseload from the cath lab. We gave them better cases, maybe slightly harder cases to do, but we designed a better pathway with CT-FFR to the cath lab. We've chatted about this. And last thing I want to touch on is CT-FFR in this trial was shown not to save money. It actually cost about 114 pounds more than the traditional pathway, which was SPECT and angiography, or PET and angiography, but these results were not statistically significant. What I want to highlight is because the current cost of CT-FFR is around 1,500 Canadian dollars, and we only foresee that coming down. So when that comes down to around $700 or $500, this should be a statistically significant finding. And importantly, what was statistically significant is less patients went to invasive coronary angiography when they underwent FFR. There are some limitations. You can't have patients with prior PCI, CABG, and MI go through it. And the clinical points being that you have to select the patients quite well. with moderate lesions to undergo FFR. So in the last few part of the presentation, I want to highlight a very special case that I was exposed to recently and the power of CT. This 74-year-old male presented to the emergency department with abdominal pain. He was found to have a murmur. He underwent cardiac investigations and was found to have mild LVH with a septum measuring at 1.6 centimeters. Cardiology was requested to do a consultation for asymmetrical septal hypertrophy. Patient was seen. He was asymptomatic. He was sent for a cardiac MRI to further characterize if this was hypertensive disease or an underlying cardiomyopathy. He was unable to undergo this cardiac MRI because of severe claustrophobia and panic. Had to jump out of the machine. A special request was made to cardiac CT. Cannot tolerate cardiac MRI. Please assess for features of hypertrophic cardiomyopathy. Okay, so we can do a coronary angiogram with CT. We know that, and it displayed, moderate disease in the proximal LAD, moderate disease which was calcific in the mid circumflex, and some mild to moderate disease in the RCA. So for an asymptomatic patient, this was okay, but let's say if he was symptomatic, I want to highlight that this is a patient that we would send to CT FFR. If we wanted to go that route and make sure that he was indeed ischemic versus not. But this patient was not having baseline symptoms. Let's see if this plays. This slide is here to highlight the spatial resolution of CT in cardiomyopathies. I'm just taking you through a mid-diastolic capture. There's a large hernia, potentially the reason for his abdominal pain. So just goes to show you that there's a tremendous amount of resolution, spatial resolution that we are able to get out of newer CT scanners. This right here is a short axis that we can generate, and we can measure all segments of the septum, lateral wall, and give you data of how thick the heart can be in cardiomyopathies, especially in hypertrophic cardiomyopathy. And as this cine is going through, I want you to keep an eye out on a big crypt that we found right here where the laser pointer is, that goes right through. It's a massive crypt. One of the hallmark findings of hypertrophic cardiomyopathy. Lastly, I want to highlight this. We can get a very clear retrospective CT, which can give us the same information as echo does. We can generate the same planes as echo. We can generate the same planes as CMR, arguably a little bit better than CMR in some cases, because the prescription for CT, the data is all there, unlike cardiac MRI. Sometimes the prescription for cardiac MRI can miss segments of the heart. So here, in diastole, we can stop the heart. And I can't do it on the slide, sadly, but we can stop the heart and give you measurements of how thick the septum is. We can give you the mitral valve physiology and papillary physiology. And lastly, we did something cool on this case. And that's the way I describe it to my preceptor, so that's the word I'll use here. We did something called latent iodine enhancement on CT. And on dual source CT, we can calculate the amount of scar that you have from infarct or amyloidosis or hypertrophic cardiomyopathy. The patient has to stay in the scanner for around about 8 to 10 minutes, and then we shoot them with radiation shortly with 2 sources of radiation, and we can actually get scar burden. So what I want to focus on this slide here is, see in this anterior septum right here, the septum and the anterior wall are not dark like the rest of the myocardium. So that's where this patchy scar is. This RV insertion point inferiorly here. And we confirm on orthogonal images that there is a high burden of patchy scar in the anterior wall and the anterior septum as well. And so this is a big add-on to myocardial characterization of modern CT. How it works is you give the iodine to the patient and you scan them around 8 to 10 minutes later, and you see the iodine contrast appear on CT. And the patterns of scar are very similar to what we see on cardiac MRI. We can diagnose epicardial, subepicardial, endocardial and subendocardial scars and give you a differential diagnosis. And the key advantages over MRI when we do this is works in patients with implanted devices, faster and combined with coronary imaging, and useful in acute chest pain, especially when you want to rule out PE, a dissection, or coronary disease. We can give you a scar burden. Unfortunately, more radiation. So every tool has a job to do, right? I'll quickly take you through that. There have been a lot of research now. This new 2025 study shows that the area under the curve for live versus CMR is very strong, and the sensitivities and specificities at the patient level and per segment level of the heart are quite high. So what this means is there's excellent agreement between CT and MRI when it comes to myocardial scar definition. This is just a cool image I wanted to put up. As we go through the heart, you can see the white areas of the heart muscle here where the scar burden exists. They're very similar to what LGE would look like on MRI. So one of the extra functions on top of just function and flow we can do with CT. So to summarize, echo has functionality beyond just standard rest echo that we can employ in prognosticating patients and reducing mortality and morbidity of the patients depending on the disease we scan for. Echo defines when physiology is abnormal, but not why perfusion is reduced. And that's where PET and flow quantification comes in, especially very important in patient populations like microvascular disease and cardiac transplant. And microvascular disease is a whole talk on itself. And lastly, CT now advances with lower radiation, better machines, better algorithm are giving us more and more capability of defining anatomy, defining ischemia and flow, and on top, myocardial characterization with scar burden and ECV agreements that we're seeing more and more with MRI. So the point of this talk being that there are very many, that's Leo. The point being, that as we're advancing into the next 25 years of cardiac imaging, more technology is coming out, and we can use these tools, if applied appropriately to appropriate patients, to get more data and make patients better. Thank you for your attendance.
Okay, we'll open up to questions. I'll open up the chat. Any in the room? We'll start off. Amel.
I have a question about one of your cases, When you show the perfusion images, you show that images are not clear as the previous patient, as there were motion artifacts. So how sure are you, or which way can you be sure your perfusion images, so your CFR images is okay? Because CFR is the dynamic requisition, so maybe your CFR measurements affected from motion. So
yeah, that's an excellent question that you bring up. So, thank you. So Dr. Guler has brought up a question saying, how are you sure that your perfusion images are artifacts when CFR is measured in the same way as perfusion is measured, from what I understand? Is that
dynamic images?
Yeah.
If there are motions, so your CFR measurements can be affected. So which way, how do you assess that these measurements are correct?
Yeah. So that's a great question. From a basic science point of view, there are some motion correction algorithms that are applied onto the dynamic acquisition as well. And from what I understand is there is some algorithms applied when the patient, both at rest and both at stress, and the scientists correct for an average motion of where the heart should be in relationship to the low-dose CT. Yes, that's my very basic understanding.
I will just say that you show really nice time activity curves, like how wash in, how wash out.
Mm-hmm. And Yeah, so, and those are our quality assurance measures that when the blood pool is being activated versus when the myocardium is being activated, those R values, those agreement values of what proposed blood flow in normal heart should be is mapped onto what the patient's heart flow is. So the blue dots, if I can go back, blue dots versus what the solid dots are right here. That's how you actually ensure that the patient actually underwent the right protocol and agrees with what baseline physiology in humans should be. I think that's what you were trying to ask, yeah.
That's great, thank you.
Rob?
Excellent talk. So I'm going to ask maybe a bit more practical question for people in the audience. So you're a cardiologist and you know CT and you know PET. So if you had somebody with new chest pain, how would you decide between CT? Let's say you have FRCPC available, which like we've talked about, versus PET versus other testing. How would you decide?
Yeah, that's a great question. So now with combined PET with CT and low attenuation CT and the advent of incremental value of all the things we can add on to PET, depending on when the patient is symptomatic and how old the patient is and what sex the patient is as well, I will differentiate those two patients. So if you have a young male, let's say an example, coming in with some exertional chest pain, and they're of a descent where you're high likelihood of having early onset coronary artery disease, I would elect for them to undergo a coronary CT. Why is that? Because, well, they're a male of certain high-risk ethnicities. We can get calcium scores off of them. We can actually get plaque burden with the amount of plaque segments, as opposed to if a female is coming in to the clinic with non-specific symptoms, maybe atypical symptoms, they're able to exert okay. Well, that population can benefit more from a PET pathway because we know we can quantify blood flow with PET and we can get information of vascular resistance. So is there microvascular disease present? I mean, we can get a lot of information with PET as well. So the first patient can also undergo PET and will get the calcium scores from the low CT. At the Heart Institute, our machines don't work at 120 kV voltage, they're at 100, so we can't calculate the calcium score, but we can give you a qualitative measure which also qualifies the patient for statin and aspirin therapy depending on how you assess. So both CT and cardiac PET now are class 1 indications for stable chest pain, but so now the selection would come down to presentation of patients and other factors like sex and your suspicion for coronary artery disease.
Thank you. We're past the top of the hour, so I think we're going to have to cut the questions there. So thank you, everyone, and thank you so much for the talk.
Thank you.